Hello, my name is Stefan Knop. I'm working at Würzburg University Hospital in Germany at the Division of Hematology and Oncology, and I'm summarizing some of the data we presented at ASCO 2020, the virtual meeting. So what we did is we performed a phase 3 study in newly diagnosed multiple myeloma up to the age of 65 years, and we randomized patients in a first randomization between RAD, so a triplet combination of lenalidomide, adriamycin, and dexamethasone versus VRD, which is the triplet consisting of bortezomib, lenalidomide, and dexamethasone. The whole study was set up as a 2x2 factorial design, and depending on the initial response, the restaging after the first cycle of high-dose melphalan, which was unique for all patients, they were then further randomized to receive a second auto transplant versus 3 years of lenalidomide maintenance if they responded very nicely, so VGPR or better, or they were randomized between a second auto transplant versus an auto-allo if they had less than VGPR. The first co-primary endpoint was the response to either induction regimen. We had already presented this at ASCO 2017, and we basically saw that patients had no inferior outcome in terms of complete response between VRD and RID. But when you summed up the VGPR and better for both treatment arms, there was a significant difference. P was 0.07 favoring VRD over RAD. And in this meeting, we presented the median progression-free and also the initial results of median overall survival, depending on either induction regimen. So again, the comparison between RAD versus VRD. So roughly 88% of RAD, but 93% of VRD patients had completed all 3 induction cycles and undergone the first restaging. And when we compare the baseline characteristics, we can see that it was a really true myeloma cohort. Median age was 58 years, and we had roughly 11.5% displaying del17p, around 4.5% of patients displaying translocation 1416, and around 4.5% displaying translocation 414. So also a true high-risk cohort within all those 476 patients. So at this meeting, we present a median follow-up of 40.2 months from the first randomization. And the median progression-free survival for patients receiving RAD was 41.7 months versus 53.7 months for patients receiving VRD as an induction protocol, which means a difference of 12 months favoring VRD over RAD. This was a hazard ratio of 0.758 favoring VRD over RID, corresponding to a risk reduction for early progression of roughly 25%. And interestingly, with this relatively short follow-up of 40 months, we can also see a trend for an improved overall survival favoring, again, VRD over RAD. So neither median progression-free survival for the induction arm was reached, but we observed 47 deaths in the RAD versus 36 deaths in the VRD-treated patients, corresponding to a hazard ratio of 0.67 or risk reduction of approximately 33%. The p-value for this is 0.07 at this relatively short follow-up. And of course, it is tempting to speculate whether patients receiving VRD as induction regimen were more likely to achieve VGPR following the first auto transplant and therefore may be more likely to undergo second randomization. We are currently figuring out all those data and will be presenting all the work in a full paper during this year, specifically also the second co-primary endpoint, which is the 3-year progression-free survival for patients achieving less than VGPR. So a true randomization between second auto versus auto-allo transplant.